A 7-month-old boy presents to the family physician with extensive scaling and pigmentation of some exposed skin areas. His mother says that these symptoms were absent until middle spring and became significantly worse after their trip to California in the summer. The child was born in December to a consanguineous couple after an uncomplicated pregnancy. He is breastfed and receives mashed potatoes, banana, and carrots as complementary foods. His weight is 8.5 kilograms, 18.7 pounds, and the length is 70 centimeters, 2 feet, 96 inches. The patient's vital signs are within normal limits for his age. On physical examination, there is a freckling, scaling, and erythema on the sunlight-exposed areas of the face, trunk, and the upper and lower extremities. No blistering, scarring, hypertrichosis, and or alopecia is noted. The rest of the exam is unremarkable, which process is most likely disrupted in this patient. Option A, conservation of uroporphyrin 3 is coproporphyrin 3. B, hydroxylation of proline and lysine in the procollagen molecule. C, base exertion DNA repair. D, NAD production. E, nucleotide exertion DNA repair. The correct answer is E. This child presents with pathological skin changes that started after an increase in sunlight exposure. Further sunlight intensity exposure aggravated this condition. The absence of involvement of other systems and the features of skin changes, extensive hyperpigmentation, erythema, and scaling suggest xeroderma pigmentation as the most likely diagnosis. XP is an autosomal recessive disease that results from the failure of the DNA repair mechanism, nucleotide exertion repair. NER. The basic function of NER is to remove thymidine dimer that form due to UVB ultraviolet light and also some chemicals. Disruption in NER results in significant damage caused by UV exposure. The incidence of skin malignancy is 1,000-fold higher in patients with XP. Neoplasms are the leading cause of death in these patients. Prognosis is good if there are no neurological developments and the patient is kept away from sunlight. There are two types of NER, global genome, GGNER, and transcription-coupled TCNER. Both variants are involved in the XP pathogenesis. several xerodermal pigmentosome repair genes XPA through XPG take place in both variants of NER. Disruption in each of these genes lead to XP. Through the frequency and the severity of conditions depend on the type. Mutations in XPA are more frequently than in XPE. XPG mutations cause the most severe variant, whereas XPF mutations result in relative mild disease. See table. Gene XPA. The function is binding damaged DNA. XPB is for 3' to 5' helicase, component of transcription factor TF2H. XPC, DNA damage sensor in complex with HR23B protein. XPD, 5' to 3' helicase, component of transcription factor TF2H. XPE binds damaged DNA. XPF works with ERRC1 protein to cut DNA on 5' side of damage. XPG cuts DNA on 3' side of damage. Both ggNER and tcNER involve several steps. See figure. Damage recognition is the first step. In ggNER, damage sensing proteins constantly scan the genome and recognize helix distortions caused by thymidine dimers. XPC and XPE participate in this process. In tcNER, this process occurs when RNA polymerase find a lesion in DNA during transcription. In the second step, a dual exertion phase occurs in which the affected SS DNA, a single-strand DNA, is removed with a single-strand gap of 25 to 30 nucleotides. This phase involves XPA, XPB, XPD, and XPF. The final step is reparation and ligation, during which an excised strand is reconstructed by DNA polymerase and sealed with DNA ligase 1. A. DNA damage recognition, global genome repair GCR, transcription coupled repair TCR. B. DNA unwinding. C. Insertion of damaged DNA. D. DNA exertion and de novo synthesis. Other types of DNA repair include review of damage, base exertion repair, mismatch repair, recombinational repair, and alloprompt repair. Option A, this reaction is catalyzed by the uroporphyrin decarboxylase. Improper function results in familial porphyria, catenyl, tartar, and or hepatoerythropoietic porphyria. Familial porphyria, catenyl, tartar has late onset, while hepatoerythropoietic porphyria manifests during infancy. Both conditions have similar symptoms, particularly photosensitivity. However, the resulting skin changes include blistering, scarring, and hypertrichosis, not hyperpigmentation and scaling. Moreover, there are additional symptoms such as anemia and red urine that are not present in these conditions. Option B, this option describes vitamin C deficiency. Although this deficiency does have skin manifestation, photosensitivity is not characterized of this condition as well. Vitamin C deficiency is unlikely in the breastfed child who is given supplemental nutrition and has no additional symptoms. Option C, base exertion repair, is another mechanism for DNA repair that is not involved in XP. Option D, NAD production impairment, results in pellagra, which is characterized by neurological and gastrointestinal symptoms and dermatitis. It is likely to occur in a breastfed child who has no additional symptoms. The learning objective, axillodermal pigmentosum, is caused by the impairment of nucleotide exertion DNA repair, which is normally responsible for the removal of thymidine dimers resulting from UVB light exposure. Symptoms include extensive hyperpigmentation, erythema, and scaling.